Welcome, everyone. Thank you for joining us today for today's webinar. My name is Cassie Gallucci, and I'm an Associate Product Manager at New World Medical. New World Medical is a leader in developing, manufacturing, and marketing cutting-edge medical devices intended to alleviate the suffering of glaucoma patients globally. Today, we are presenting our second episode of the ClearPath Conversations webinar series, highlighting the Ahmed ClearPath surgical and ligation techniques. This webinar will be presented by world-leading glaucoma surgeons, Dr. Paul Singh, President of the Eye Centers of Racine and Kenosha, and Dr. Lorraine Provencher, cataract and glaucoma surgeon of Vance Thompson Vision. Just a little housekeeping before we get started. The webinar will be recorded for educational and training purposes. Please mute your devices, and if you have any questions during the presentation, please type them into the question box in your Zoom control panel. The surgeons will bring them up during the presentation, and we'll also have time for the questions at the end. Now, without further ado, we will turn the time over to Dr. Singh and Dr. Provencher. Let me just start sharing my screen.
All right. Well, thank you for that intro. What's happening, Lori?
Not much, Paul. Good to hang out with you.
It is so
Can't
good
wait to have tacos with you on a
It's
Tuesday. It's
Tuesday.
Tuesday.
It's Tuesday, so we're gonna have to do a little Taco Tuesday. We'll talk about that in a second. But well, first of all, thank you to Cassie. Thank you to New World for the opportunity to talk about tubes. Lori and we've talked about MIGs for so long. I'm like, oh yeah, we get to talk about tubes because no matter how much we love our MIGs, we love our SLT and our drug delivery, we still need our tubes. We still need them. And the ClearPath has been a really fun tube for me to work with over the last few years. And I know, Lori, you've had some great videos we'll share today. And I just want to preface the audience tonight. There's not a lot of data. This is not a data dump, I promise you. The goal tonight is to provide you with some pearls, some techniques that we utilize at least, and we'll probably differ with some of the techniques that we utilize, but to hopefully share and kind of help maximize outcomes in your practices. So it's really more of a technique, personal opinion type of a webinar. And then maybe we can talk about how we use different tubes from Ahmed, FP7s to ClearPaths, kind of where do we use non-valve tubes versus valve tubes, et cetera. But that's the premise behind this webinar as well. But I've been using the ClearPath, and I think what's unique about the ClearPath, as we'll talk about, Lori, is just the fact that it's so malleable. The silicone material allows us to really bend it, so it conforms because of the shape of the curvature and because its profile is very thin and it has that like malleable material. It really does fit through smaller incisions, which we'll talk about with one of my techniques, the taco technique. But also, just it hugs the sclera so nicely when you way back there. It just kind of stays nice in place. And so I think for those eyes, especially if you're trying to get a good view, it's just nice to have that hug back there. I think the low profile really allows for a nice diffuse low-lying bleb when it does open up eventually as well. What are your thoughts just in your experience? I'd love to hear before we get into technique, just kind of what you've used it, what kind of patients, and how your experience has been, Lori, so far.
Yeah, I think this is one of those implants where the first time you try it, you immediately see the benefits, and it's very easy to love. I pretty much switched all of my non-valved implants to this Ahmed ClearPath implant just because of the things you mentioned. It's very easy to use. It's very familiar. It's very low-lying and flexible. So when you're putting an implant in a quadrant around muscles, I think the least disruptive you can be, the better. And so I've had really nice outcomes with it. And again, it's still a non-valved implant, and I tend to use the 250. We can talk about when and why we do that, but I think it's a single quadrant implant. It's very minimally disruptive, and I've had really, really nice results with it. So really no complaints, and I, won't have a lot of earth-shattering watch outs to share. I think just some little tricks along the way. If you're interested in kind of getting to know this device, I think we can make it easier for your learning curve with tonight's webinar.
Yeah, absolutely. Well, what we'll do is we'll go through some videos. I have one video. I know Lori, you have a couple of videos. We'll kind of go through them, and I'll maybe pause along the way, kind of talking about some of the techniques and some of the pearls that we use. And then through all that, please ask any questions. If you guys have any questions out there, we'll stop and answer questions best we can, because I think that's the most fun, having it being interactive and hearing what you guys out there want to talk about as well. So with that said, let's go ahead and next slide, and we can try to see if we can share one of my taco technique videos. So Cassie, if you can go ahead and just share this, and then we can stop along the way if we need to as well. So this is one of my taco technique videos many years ago. I realized when it was so small, I was like, I can fold this into a taco or even like into a cigar and just roll it and fit through a really small incision. So this is my small incision tube surgery. It's a patient who had previous trabeculectomy, failed trab. I think it was a Zen in the superior nasal quadrant. So the technique I learned at Duke was really with making an incision about 3 to 4 millimeters behind the limbus versus doing a limboperitomy. But I'm only making about a 3 millimeter opening in the conjunctiva. So this is a small incision about 3 millimeters, 3.5 millimeters or so in length. So I'm cutting down. This is a patient who had a nice, good size tenon, still good, soft, mobile conj. Like anything else, you want to really make sure you have good, healthy conjunctiva with any subconj surgery if possible. So I'm dissecting. You see how nice thick that tenons is. So that's going to be important later on because I like to use that tenons as help to help me cover the plate and the tube as well. But I'm just going to dissect back behind the underneath the tenons, back behind there as well. Just use my Westcotts and really get underneath there to create enough space, enough pocket for that plate to sit. So I'm going to go temporarily here. Just go underneath. Remember, you want to keep your scissors closed as you're going in, open them, and then come out without closing them back because you don't want to inadvertently cut something on your way back out. So we always taught to keep it closed going in and then spread it and then come out. So I'm just going underneath and I'm holding tenons. This is obviously basic stuff, everybody, but I really think it's good to just make sure you always try to hold tenons, don't hold conj, because you can rip conj. And depending on how thick that tissue is, sometimes if he's really thin, frail, post-mitomycin conjunctiva, and if you hold that conj, it can rip pretty easily. So I'm pretty aggressive. Just going to go ahead and now do a little hemostasis with my Wexel. Now I'm testing the tube, the plate, just using a 30 gauge cannula with some BSS, making sure the plate's functioning well. So here's my ligation. So I'm going to talk, and we'll talk more about ligation later on, but I use a 5-0 Vicryl, and I love 5-0 Vicryl. Everyone uses 7-0, but I think 7-0 can be hard to really pull, and you can sever sometimes the tube with a 7-0 Vicryl. So the 5-0 Vicryl I like a lot, and it opens up to me more consistently because I get around 4 weeks or so, it really does open up nicely. And I can pull really hard and it doesn't really sever that tube. And so I can really ligate it and feel really confident that it's now occluded. I'm just going to test it again. You can see how it's nice and occluded. I took the ripcord out, so I don't use the ripcord for most of my cases, but we'll talk about that too, Lori. Then I know you have a really cool ligation technique. But here's that little taco technique here. So I'm really folding it into like almost like a cigar kind of thing, like rolling it, and then I'm unfolding it while it goes in there. So I'm pushing it all the way in, and once it's in, like a taco basically there. And so once it's in there, I'm just gonna push it in, and it just naturally unfolds while it's already underneath the tenons there. So once you get that initial portion underneath the tenons, it'll just find its way and it just opens up, and that's it. And so it's a way to keep that incision nice and small, and the key is just get it underneath that tenons and shove it back there as well. And what's nice is that you can actually really maneuver it nicely because it has those eyelets that are anteriorly positioned. What I love about the ClearPath is it has these anteriorly positioned suture eyelets. So exposure used to be a big issue, especially if you're doing these small incisions. How do you get a good exposure? Well, the good thing is you can be like 7 millimeters back behind the limbus or so, and because these suture eyelets are anteriorly placed, the plate is really further back. So you don't have to be as far back with your suture eyelets as you have to be with some of the other plates. So I'm about 6, 7, 8 millimeters behind the limbus with my suture eyelets here, and using a Nido nylon suture just to secure this. And the plate hugs the sclera so nicely that it doesn't move around. You can see I'm not really having to fight it lifting up or having to kind of come off the sclera. It just stays on the sclera nicely. And this is about 7 millimeters or so behind the limbus there. So, that gives you enough space. And then about 2.5 millimeters behind the limbus or so, I'll use my 23 gauge needle. Again, beveling up and into the sclera here, being a little bit more superficial here. And then once I reach the limbus, aiming down towards the anterior chamber here. So sorry, I'm losing my view a little bit there, but I'm going in the sclera, going to go ahead until I reach the limbus there. And then I'm going to go ahead and enter with the needle. It's going to pull down here. You can see I can center myself. Use my 7-0 Vicryl stay sutures for traction, enter into the anterior chamber and try to be as parallel. And I turn left and right. I'm not sure if you do that too, Lori, but I like to turn left and right just to make sure I have a nice, clean needle track there. And I like to be as parallel and as deep as I can in the anterior chamber, so that way I'm away from the cornea, parallel to the iris. And I beveled up. I already cut the tube to the appropriate size with the bevel up fashion with my Van Ness scissors, and just going ahead and now entering the anterior chamber through that needle tract as well. You can see it entering. I like to keep mine pretty short. I don't like to keep it too long. As long as I'm deep in the anterior chamber, I like to keep it kind of short. And they're about 1.5 millimeters into the AC as well. Now, here's a kind of a unique feature. I do close it with Tutoplast, with clear cornea, different things. But if I have thick tenons, like you saw, this is the kind of patient where I'll use amniotic membrane. This is Ambio 5, which is amniotic membrane, but it's a thick. I forgot the actual micron thickness as well, but I use about 4 or 5 of these layered on top of each other, and so it lasts for a good few weeks, a good about a month or so, month and a half at least, if not longer, and it covers the tube and the plate really nicely. I don't suture it down, and I close the tenons over that. Now, what I'm doing, by the way, is making these venting slits with my super sharp blade. I used to use a needle and the needle itself of my suture to do it, but what I do is I use the 15-degree blade. I don't know if we can go back there and if we can rewind it a little bit there, Cassie, and just pause it there. I just want to show something real quick. Um, why I'm going to pause is because, okay, you can stop there. So what I do is I go until the tip of that 15-degree blade reaches the other side of the tube. And then I come back and I just twist a little bit and come out. And what that has done is really given me more consistent flow post-operatively. I used to use needles and go back and forth, which is a great technique, but I found that it wasn't always consistent with how much flow after surgery I was getting, and the IOPs would be anywhere from 10 to like 30 the next day. But with this, I'm getting decent flow. I don't get hypotony, and I'm getting down at low teens with this technique. So I go until the tip of that 15-degree blade is on the other side of the tube, and I come out, and as I'm coming by, I twist it a little bit, like turn it, and then come out. So you can press play again. Just want to kind of clarify that. I make about 3 or so of these to make sure I have enough flow. So now I'm closing tenons and the conjunctiva as well together. And that when you have a thick tenons as well, that really does make me feel much more confident to use amniotic membrane. It's really nice because you have a nice low profile with the amniotic membrane. It's anti-inflammatory and it forms a nice epithelial layer. And we have not seen significant issues with erosions with this amniotic membrane, especially if I have good, healthy tenons like you see there. And because it's a small incision, just do a couple interrupted sutures. And I haven't seen issues with erosions with this technique as well. So the small incision has really helped with less trauma, less suture time. And again, with sometimes if you don't have a lot of real estate, you don't have to make as big of an incision as well. And that's pretty much it for my technique there. We can stop it there. This is just doing subconjunctival dex and antibiotic as well. But Lori, I wanted to stop here, get your thoughts, have a good discussion on a lot of the technique, and come from front to back, and get your thoughts on the taco technique. Do you use it? Do you not? What's your thoughts on that?
Yeah, I think it's a super cool technique. I haven't used it, but you might have just convinced me. I do have a few questions. So some of these I might know the answer to, some of them I don't.
Okay.
How do you actually roll it up? Do you use your fingers? Do you wrap it around a device? Do you have any, because it's so small,
It
I could
is.
see it being difficult.
It can be annoying. It is. So yeah, you are literally just like rolling it up like a cigar or
Okay.
something, a piece of paper, and it can slip your gloves and stuff like that. So yeah, so you have to kind of, and then sometimes you put it in there and it unravels before you actually release it fully. So there's a little bit of a nuance to it. We actually are working with Mateen and some people working with them on making a loader where you just kind of you put
Mhm.
it on this little device and you just twist it and it fits into like a cigar and it can fit through like a 2 millimeter incision. So we're working on that, but for now it's just a manual rolling. Exactly.
Yeah, that'd be really cool. Then you could just stick it in there and kind of deploy it. That would help a
Yeah,
lot.
absolutely.
Um, so it's funny. It seems like so many features of the ClearPath are designed to make life easier. So I think your point about this technique is really hinging on the fact that you have more anterior fixation. Because if you were trying to get 8 millimeters back from the limbus with this, it would be a lot more challenging not to have to open the conj a little bit more. Your point on tying off the tube with the, you said a 5-0 vicryl?
Micro. Yep. Yep.
Yeah, yeah, I think that makes a lot of sense because when you're trying to get that compression of the tube, you really do have to crank down on the suture. Have you, I use 7-0. Have you ever severed a tube? You really have.
Absolutely,
Okay.
twice.
You are clearly stronger
Not,
than me.
but to be fair, it wasn't a ClearPath, it was a different tube. But yeah, the same
Okay.
principle. I mean, I think, you try so hard to make sure you're ligating it. You're like, I gotta make sure I don't have any flow. I don't want hypotony. I don't want
Mhm.
hypotony. And then you just go, oops, because it is so sharp. And if you have a lot of pressure and a lot of force with those needle holders, it can sever it. And one time I had one that I didn't realize I severed until I was like already like putting the tube in the eye. And it was like, oh, I did sever this before. So that was like a pain in the ass. I had to take the whole thing out. So yeah, I just find the 5.0, it does compress even easier because it's wider and bigger, and it's just you can pull as hard as you want, and it just does not sever, and it gets more control too when you really want to kind of pull on those sutures. So that's kind of what my default now. What you're using a 7.0 now? You said
Yeah, I use a 7.0. We can talk more about how I like to
ligation.
tie it off later. But yeah, I thought your point was interesting because I've had a few folks ask me about severing the tube. And I personally hadn't, but I must not hit the gym as much as you do. Um,
That's strong something.
One thing I thought is worth highlighting, and I think your Amio 5 is really interesting and it's slick and it looks beautiful. But I think it's important for the audience just to know how crucial it is to have some sort of support there below that tissue because patients obviously tenon changes as patients get older. This is going to be there for the rest of their life. So having either, like Paul said, a corneal graft or a scleral graft or pericardium or amniograph like this is really important to add that extra support, especially early on when they're healing. So just wanted to add that.
Yeah, if I have very tight tissues, very thin conj, or like no tenons or very little tenons, I won't use this. I mean, I'll use it maybe in addition to something else, but I'll use a pericardial patch graft, or I like cornea. Clear cornea looks
Yeah.
really nice. It's really clean. It's I think cosmetically we'll talk. I mean, I think you have a nice case on that. So I think that definitely a good point. You want to make sure you have something to cover the tube because if you just close conj over that and just tenons alone, it'll erode.
Yeah.
It's Trust me, I've had it happen too many times. So
Right.
I think we have a question.
Exactly.
We have a question. With using 5-Vicryl, how much longer does it take to dissolve? Believe it or not, not any longer. In fact, because a knot is bigger, it actually opens up a little faster in some ways, I found. So I have not seen the 5-Vicryl last longer than a 7.0. In fact, sometimes a little bit earlier. So that's what's kind of unique about it because it's a bigger knot. It doesn't get too tight in some ways, so it unfolds and unravels a little bit easier and dissolves a bit better in what I've seen.
Hmm. Yeah.
Question.
Great question. I had wondered that too temporarily and then I forgot. So I'm glad somebody asked. All right. I think Cassie, we can move on to the next slide. This is a sped up video of mine. I didn't have the time or bandwidth that Paul does. He's amazing. He sleeps way less than I do to do a nice edit. But this is just a sped up version. I make a fornix based conj opening there for about 2 to 3 clock hours. Again, I was trained on implants that were a little less foldable, so I needed good exposure. But in general, I'm kind of a control freak and really like to know what's going on with the tissue surrounding the implant. So this one I did not use a ripcord on. I did have to tie it off twice because my first one was a little leaky, so we can talk more about that later. But again, I'm fixating in a similar spot to Paul and a similar little tunnel there. It's super important to come out parallel to the iris, not having it projected up towards the iris. And you almost have to overcorrect with your needle sometimes, Paul. I feel like you have to kind of almost overcorrect in your mind that you're going to come out there parallel to the iris. I do fenestrations as well. We can talk more about that here in a second. And like you mentioned, I like this clear corneal patch. If you could go back for a second and pause, Cassie. This is way faster than I thought it would be. Um,
You're faster surgeon
I
than I
like
am.
no, this is like ultra speed here. But I like the clear corneal patch for multiple reasons. I think it like you said, aesthetically pleasing. It's going to integrate into the tissue and be very, very nice. Patients aren't going to say like, "What's this white thing on the top of my eye?" Especially for patients that are a little more pigmented, they might really notice a scleral patch. So the corneal patch is great. I also like that you can see through it, so you can see what the tube is doing. Sometimes you could even do sutures that you could laser. So some people will do like a laserable nylon or something like that around a tube implant that gives them more permanent occlusion but control, so you could release it later. So you can laser through these And you can actually laser Vicryl as well. So you can laser through these corneal patches. So I just secure it down there with Vicryl. You can start the video again. And then I close my conj. I use a wing suture at either side of that opening, and then I run it back a little bit. So it ends up looking really nice. I'm using 9.0 Vicryl here. I use 8 or 9.0. I went through a 9.0 phase. It's a little more comfortable, but a lot harder to use because it's pretty springy. And then I typically have gone back to 8.0 Vicryl because it's a nice balance of comfort and workability. So, and then I do the same thing as you, Paul. I use Ansef or an antibiotic and a little steroid injection at the end. So
Nice.
different opening, much larger, obviously, but the exposure is great. So if you're kind of uncomfortable at all with your anatomy and you're still trying to figure, disclaimer, I'm not uncomfortable with anatomy. I'm qualified to be here, but I think you get your technique down. You really like it. I like this one. I think it's good for seeing all your anatomy, seeing where you're at, making sure you're not over a muscle or something like that, because this is a single quadrant device. You don't have to worry about going under muscles with the 250, but it's still kind of nice to make sure you at least have those landmarks. So when you're opening that conj, whether you're using Paul's technique or my technique, just kind of identifying those muscle insertions, I think is still really important.
Yeah, just to know where you are, because you can get confused. Am I really in the superior temporal quadrant or not? And you're like, oh, I'm a little more temporal than I thought. So yeah, knowing the
Yeah.
landmark before you. Sometimes I used to mark before I turn the eye downward. I just mark where temporal and 12 o'clock was.
Mm-hmm.
I would get confused. I'd turn the eye downward, and you don't know how far you're turning and how far the eye's torquing, and you're like, oh wait, I'm
Yeah.
temporal. So really good point there. But no, that was a
Yeah, if they're
beautiful.
blocked too. So if a patient's blocked, they might tort the eye. They also, when they're laying down, their eye's going to tort. We all know that. But look, like typical landmarks, like a pinguecula, can be really helpful. But really avoiding that temporal conj can be really useful, because that is any conj that's in the sun exposed band, their nasal or temporal, is going to be a lot thinner and a lot harder to close and work with. So keep that in mind, as if you can kind of structure your incision in a way that avoids that thinner area, that can save you some time at the end when you're closing things up.
No, love it. Quick couple questions first of all. How did you close the cornea? Was that 8.0 Vicryl used to close the cornea?
Um, no,
Secure
that was 7.0. So
7.0?
I open up 7 and 8. So I have 7 to put my patch on, 7 to tie off the tube, 7 for my traction suture, and then I save 8 for the conch, and I use it on a BV needle. So you only have to have 2 Vicryl sutures with this technique.
Okay. And then which needle did you use to create your venting slits again? Or venting
Yeah,
opening?
so the fenestrations, I use my 7.0 Vicryl needle.
Okay.
I have it already in my hand right there because I'm sewing on my patch. The way I think about fenestrations actually is I kind of do a fudge factor in my mind, like where they're starting out and how many meds they're on. And if I want to drop them, say 10 points or 1 med, I'll use 1 fenestration. But what I really do is after each fenestration, you can tank up the pressure in the AC with BSS, kind of like you do with a trabeculectomy, and just wait for a minute to see how much flow you're getting through those fenestrations and kind of titrate that pressure. So you could keep going until you feel like pressure is in that low teens range that you typically are going to want for these patients. So it's reasonable if you want to take the time to fenestrate according to where the AC pressure is resting.
I love that idea. And I think that's really important because, despite how many drops they're on beforehand or even where they start with, we know after surgery, if you have this tube in there and if it's fully occluded, not functioning, the pressure will go up pretty quickly. And
Mhm.
so I like that idea. And how long, in your opinion, with the type of kind of fenestrations you do you feel like it works before the pressure starts going back up again? Do you feel like it lasts until the tube opens up or in like a week or so? What do you think?
I think it's variable, and I think it depends on the patient's tissue generally. So the video you showed, all that tenons, I don't know. No matter what you do, you probably are going to go back up a little bit before the tube opens. But I would say at least a couple of weeks typically with fenestrations for me. Um, and it's nice when they last until the tube opens, because when you have to add back aqueous suppression and then they're aqueous suppressed and the tube opens,
And it's like
not
crap.
an ideal combination. Yeah.
Yeah.
So, I mean, tubes are very predictable, actually, I think. I don't know. I think we all have our roller coasters with tube implants, but you can get a rhythm down, and maybe we could talk about this later, but kind of what to expect along post-op period, and when to see patients, when to change medications, stuff like that.
Yeah, no, let's do that. Let's do that at the end because
Yeah.
I think that's a great point, and I'm learning from everybody too all the time. So, a great case though. Thank you for sharing that as well. I think you have another one too, right? I think
Yeah, I do. And it's just as fast, gosh darn it.
it's so
Um,
damn fast, Lori.
I'll have to slow it down a little bit. This is a 350. So I don't use 350s very often, but I wanted to share it. Same conj opening here, about 2 to 3 clock hours, getting nice exposure into that superior temporal quadrant typically. And here I do hook the muscles. So I need to know where they are, and I need to make sure I get these wings under the muscle. So usually I have a muscle hook in one hand and a grasper in the other hand, and I'm kind of sliding it up under there. This low profile of the ClearPath is really nice because it glides up under those muscles very easily, but you just want to make sure you have the entire muscle over that wing. And then this patient, I'm actually putting it in the sulcus.
Nice.
So
I
she
like.
wanted to wear contacts. So I'm going to go a little further back, about 2 millimeters back from the scleral spur. And you just stick it in the limbus, and you want to go bevel down. So if you'll pause there for a second, Cassie.
Yeah, let's talk about that. Really
Yeah,
important. Good
yeah.
point.
So the whole point of a bevel is so that it doesn't get occluded by the iris, right? And so when you're in the anterior chamber, the iris is under you, so you want bevel up, so you have as much of that bevel open away from the iris. When you're in the sulcus, you want the bevel down towards the IOL, and so less likely to get occluded by iris that way as well. Am I right there, Paul?
I love it. We
Yeah.
appreciate it. Love it. Absolutely right.
Yeah.
And yeah, I think you're looking at tubes are awesome, but as if you've done tubes and you've been in practice long enough, like I have, you will see some endothelial issues sometimes, depending on how you place that tube. So I mean, when in doubt, if it's a pseudophakic patient, I have a strange cornea, strange endothelium, strange AC. I think a sulcus tube is a great option. I really really like it a lot. It does take a little bit of a unique feature. There's different ways of making sure you're in the sulcus. You did a great job there. You kind of know your landmarks really well. Sometimes people will come from the opposite end with their needle and go
Mhm.
from like the opposite of and then go through the antechamber underneath the iris and come out the sclera and then grab the tubes. That way you know exactly where you are. So sometimes it can be a little bit of nuance to feel comfortable going into the sulcus, but in these pseudophakic patients, I think it's a great option. Do you do this only for these kind of patients, or do you now mostly do for pseudophakic patients sulcus tubes?
Um, I typically still do AC tubes because I'm pretty picky about where I put it, and I like how well you can visualize it when it's in the AC. And also, it's easier for other doctors to see it too and know it's there.
Yeah.
Because some of these posterior tubes that are low lying, people could miss it if it's in the sulcus. So, um, if they're a contact lens wear and I want, minimize any chances of that a contact rubbing over the tube, or like you said, if they have any corneal endothelial issue. Sometimes if they're young and pseudophakic, it's really nice to do it because the longer this tube's in the eye, the more likely they are to end up with issues down the road. So it's a really nice technique to know how to do, and patients really appreciate it when you're able to keep them in contacts if they are a contact lens wearer. But maybe Cassie, if you could back up just a little bit to where I'm entering the needle.
Yeah, let's go through that again.
Yeah,
That's really
yeah,
important
go
because that's
right there. Yeah, go ahead and I'll tell you when to stop it. So stop right there. So what you can see is you have the tissue open. You'll see scleral spur, which is just like a little white band on the outside, and you can use a weck to move any blood away so you can identify where it is. And you want to go about 2 millimeters back from that. So that gives you about a millimeter for the iris and then a millimeter into the sulcus. You could even go a little more posterior to that. And you just go, parallel to the iris still, except this time you're below it. And what you should see is your needle will come out over the optic. Now, sometimes it can be hard to tell if you're over or under the optic, so it's okay to kind of dimple that needle down and see if it moves the optic in a way that you would expect if you were on top of the optic. Or you can go in with another instrument in through a para and actually touch the two to make sure you're actually above the optic. But that's typically how I do it. If you have to make a couple passes, the tip there would be to always pass above or below exactly where you were, so that you don't have multiple poke holes in the sclera, and you'll get hypotony issues with that. But if you go above or below directly where you were, then you'll tint up and close that prior sclerostomy as you create your tunnel and put your tube in there.
Yeah, and if you go slow, you can kind of see it almost. If you feel like you're too superficial, you'll see the iris moving a little bit there just before you even start going in there. So if you feel like, okay, I can see the iris moving now, back up a little bit, then re-engage and just go a little bit further deeper, like kind of re-angle yourself. So to Lori's point, don't come all the way out and have a whole new pass. Just kind of come back a little bit there and just kind of go a little bit deeper. So paying attention to what the iris is doing, I think is
Mhm.
really important as well. And then also the tube length. They talk about, do you do a different tube length for the sulcus? Because I think that's really important too.
Yeah, so I actually still trim them the same way because I want them a little bit longer in the sulcus so I can peep out and see it kind of peeping out. I love that word, under the iris. And so I don't really adjust it because when you're entering more posterior, it's going to end up a little bit longer anyways. So the way I trim my tubes is I actually lay the tube like relaxed on the cornea. You don't want it taut because then it'll end up too short. So I lay it relaxed on the cornea in line with where I'm going to put it in. And then I just trim it. I kind of start my bevel actually just inside the limbus. And it always feels when I teach fellows, it always feels to them like it's going to end up too short, but
Yep.
it works out really well. And I think your video showed it very well, Paul, like how you like to trim it.
Yeah.
And because you do exactly what I did.
Yeah, no, it's a really good point. I think I like to leave it a little bit longer than the sulcus too because I like to be able to see it when I've dilated pupil. To your point, it's hard to sometimes see those sulcus tubes, and if it's too short and you really don't know, and you're like, is it really in there? Like I have no idea.
Mhm.
And so keeping it a little bit longer, I'll sometimes trim it the same, maybe even leave it a little bit longer when I'm in the sulcus because I like to kind of see a little bit, through even an undilated pupil just to make sure it's still there. But
Mhm.
that's the key, just making sure you can see it and paying attention to the needle where you're entering. What I was trying to say before is there are some people who kind of will take that needle and go 180 degrees away, enter through a paracentesis through the anterior chamber, go underneath the iris, and then come out through the sclera towards you, right, to where she's entering. And that way you know exactly where you are. You're in the sulcus. That's what, like, especially if you're starting out, you're not really comfortable with the sulcus. That could be a nice little trick to make sure you are in the right position. But this is beautifully done, though. Really well done. How do you position where you're going to enter your tube? Do you curve the tube and go at 12 o'clock? Do you always like to be at 12 o'clock? Talk about that a little bit too.
Yeah, this is really important. So repairing erosion sucks. And I was in an area previously where I was repairing a fair amount of erosion from a tube implanter who retired. So it is very difficult and challenging to repair tubes, but so you want to do everything you can in your power. We're all subject to this as we have an aging practice, but you want to do everything in your power to avoid it. So I like to position the tubes where they will enter in a way that is very well covered by the eyelid. So tube erosions typically occur 2 to 3 millimeters back from the limbus. It's like a classic area. And it's right, if you're entering the tube too temporal, that lid margin where most of us have chronic inflammation is going to be constantly resting on where that tube is entering. So it's more likely to get exposed. So even though we're making a superior temporal opening, I try to snake the tube, like you said, where it's entering almost closer to 12 or just off of that a little bit so that it's going to be well covered by the lid throughout the patient's lifetime. And you can direct the tube that way with like a vicryl stay suture or something, this suture it to the sclera. You can snake it. Or if your tube is trimmed and it's too long, you can purposefully snake the tube a little bit too, just to pull it out of the AC a bit. So snaking a tube is something that I actually frequently do.
No, I love that. Great, great points. We have some questions, by the way. I want to make sure we don't ignore the audience because it's awesome to see questions. So thank you, everybody. Yay. So Stephen asked, great videos. Great job, Lori. But what factors make you decide to implant a 350? So you mentioned a little bit that you don't do it as often, but kind of tell us why would you do a 350 over 250? And do you feel there's a difference efficacy wise?
So data would tell us that there probably isn't a major difference between a 350 and a 250. In fact, there's probably not some studies that looked at a 500 versus a 350. There wasn't a whole lot of difference. However, the one situation that I do use a 350 is if it's a patient who I was going to do a trabeculectomy on, like they need a really low pressure, and for whatever reason, say they can't come off of blood thinners or their ocular surface is too much of a inflamed situation, and I end up switching them to a tube, I will use a 350. You like to say hedge your bets, Paul. So I'm trying to hedge my bets if there's any difference, because studies are all averages, right? So if there's any chance that this 350 could make a difference in this patient, and also the trab versus tube study was 350s. So there's a little bit of data there for method to my madness, but that is really the small situation where I would still go for a 350 because it is
Yeah.
a little more challenging to get in.
And I'll be straight up. I pretty much only use 250s. So
Yeah.
so yeah, I really can't answer that question with any kind of clarity except for so thank you for Lori for answering that one because I'm a 250 guy. Maybe I'm just too lazy now as I'm getting older. But a couple more questions. So thank you for that answer. So Billy, thank you for the question about uh, showing videos to colleagues who see the taco technique but haven't really dipped their toes in the water and really done it. A lot of it's comfort level. I mean, I think for me, I just love less dissection. It's a faster surgery, less dissection. I feel like I don't have to do as much for the wound. If you don't have I mean, the key to the taco technique is to make sure you dissect. Lori did a great job of opening up and having a good view. But I think the key is so when you have that nice view, you also are removing tenons and really getting a beautiful, clean Blair sclera for that plate to sit down on, right? And then you close it nice and evenly, so you have a nice diffuse bleb. If you don't dissect enough with the taco technique and you have all those tenons junk in there and the tube sitting, the plate sitting on there, it doesn't sit well, and then you might get more fibrosis, etc. So the key of the taco technique is really, really good dissection with a curved Stevens or Westcott, whatever you need, but really making sure you give that space and create that pocket. But what I like about it is more efficient. If you don't have as much tissue in the conjunctiva, you don't want to, it's hard to close. I think it's nice to have a smaller opening as well. And I really think a reason why some people are afraid to do the taco technique initially is because they are afraid about, am I going to have enough exposure, like Lori was saying, with some of the other plates. But with the ClearPath having that anterior located suture eyelets, it's not really that hard to get that suture eyelet, at 6-7 millimeters back there. You have a really good exposure because you're making your opening at 3 to 4 millimeters behind the limbus. So it's easy to get that good view. So long story short, I just think it's a more efficient surgery. I feel like the eye less conjunctiva is cut. I feel like the healing is a little bit faster for some of these patients. But again, there's no right or wrong, whatever is convenient for you. But that's kind of why I do the taco technique as well. And like I said, to each his own, I guess. But hopefully that helped. And then Guggen, you had a good question. What's up, Guggen? Guggen Sani out there, everybody. So do you use long scleral tunnel and or employ a patch graft? If you use a patch graft, which patch graft do you use? So we talked about patch grafts a little bit there. I like to do at least a 2.5. I like to do about a 3 millimeter tunnel. I really think the further back from the limbus you can be with your tunnel, the better it is. When I first started out after fellowship, it was like 1 millimeter back, and I would get a lot of exposures, a lot of dysthesias. It's not great. So being as far back as you can, I've actually gone it back even like as far back as like 5, where I really have to do a long tunnel, which can be kind of a pain. But at least 2.5 to 3 is what I want to be at least. And now to answer the question about patch graft, but Lori, what do you do in terms of your tunnel? How far back do you want to be at minimum?
Yeah, I always try to do as much as I can, at least two. Um, I think the important thing about a tunnel is if you think about the anatomy, when you're tunneling through sclera and you pop into the AC, your tube is going to be projected right up towards the cornea, which you don't want. So that's what I was mentioning when I said you almost have to overcorrect. So you're tunneling. Once you get just over scleral spur, you're gonna like overcorrect and dive into the AC, and that'll help get your trajectory flat to the iris. And it's, in my opinion, okay for the tube to touch the iris as long as it's like not indenting into it, or you don't want it chafing, but you'd be surprised how well a tube will rest on the iris and not cause problems, even in patients that you would think would have issues, like young pigmented patients who are a little more prone to inflammation.
I've actually had a couple where I thought I was going in the sulcus and I came back out of the iris up into the anterior chamber. And that worked really well, actually. So went under the iris, went through the iris, it came out of the iris up top. And I was like, okay. So I left it there. But it worked really well. I've had patients kind of sitting there and doing great, great. So yeah, I think it's very forgiving. I think the better to be deeper and away from the cornea, the better it is. So that's the idea as well. But yeah, good point. I use a lot of amniotic membrane. Again, like I said, if I have a nice, thick, healthy tenons, healthy conjunctiva, not a lot of tension. If I feel like there's a lot of tension, tight conj, I'll do something more robust like a cornea. is really strong, or even like some type of pericardial patch graft. So the two I use is pericardial patch graft, like a Tudoplast, and then cornea. Those are the two I use. I don't usually use sclera anymore as much. And then for me, that's kind of my two go-tos if I don't use amniotic membrane. Okay.
Yeah, I agree. I just use cornea. I love it. It's the
Love
only
it.
cornea surgery I do.
Hey, you're a cornea surgeon. Why not, right? Actually, I've actually I had a tube repair for a different tube where it had a hole in the eye. Basically, it was melted, so I had to use a corneal graft to actually close the sclera up, basically. And
Mhm.
it's it's amazing how strong it is. But yeah, great stuff. Let's go. Let's keep going because I know we're already at almost time. My gosh, that was fun. I
That's
learned so
fun.
much.
45 minutes is not enough, so we can keep
Wow,
going.
man. You're like already okay. Well, we'll try to do some ligation technique talks and discussions here, videos. This is a video on, I think, my ligation technique. And kind of I mentioned earlier already on is it playing? I don't think I'm. There we go. So I just think it's a good to test the plate, even though it's always patent. It's just good to test it. I do it with the Ahmed FE7 as well. But this is my ligation technique again. Like what I like to do is I like to really make sure that I'm using that 5-0 and I can just push. I can pull as hard as I can, and then I just kind of keep pulling and keep pulling. And you see how the knot's kind of a little bigger than the 7-0. It doesn't really. Sever. I mean, I've tried hard to sever it, and I have not been able to sever. And so now you can just see here me closing it up. I know you have a cool technique we're going to show in just a second, but it's a simple technique. I'll do it either after the plate's already secured, or I'll do it right before I put the plate in there and just kind of have a technician help me keep it still and hold it because it can kind of flop around. And then these are my venting slits I call them, or your fenestrations. But again, I go across until the other tip has been to the other side. And then again, this is my tenons I was closing. You can see here just to show you. This is another one with a nice healthy tenons as well. So it's very, very important to do a healthy tenons if you're going to use the amniotic membrane. This was actually a Tudoplast. That white was a Tudoplast I'm using here. And just closing it up with two sutures, and that's it. So my ligation technique is the same for every patient. It's 5-0, pull really hard, and it works all the time. That's mine. Simple. Nothing fancy on that one. All right. Lori,
Love it.
let's see your octagon technique, whatever it's called.
Octonot.
There
Four
you
knot
go.
or eight knots. Okay.
Okay. Let's hear it. I want to hear. I want to learn from you.
Let's see if we have audio. Let's use audio if we have it. Maybe not. That's okay. I can just go over it. So I found that with the ClearPath, I was needing a slightly different technique. My typical 311 with the ripcord in there was not as watertight as I like, and I like it to be completely watertight. So I don't think the video's always fully rolling. Oh, there we go. Okay. So Paul mentioned having a tech to help you. I think it is helpful to have the tech put their finger on the plate to stabilize the whole unit. Otherwise, it's going to tiddly wink around when you're trying to tie it off. But what I do is a typical 3-pass here, and cinch it down. So pausing to really cinch is important, and you got to cinch carefully so you don't break it. And then I flip it. So you flip the ends, and that 3-pass will flip under the tube. And then you do the same thing on the other side of the tube. So you throw another 3-pass. So it's sort of like a modification of a lasso. So you throw another 3-pass and cinch it down really well. And what that causes is a nice like locking cinch on either side of the tube. So you get compression like this, like a sandwich. And then you just do a 1 and a 1. So that's where the 8 comes from. And almost always, I would say, I can't remember the last time this doesn't work. This is a very effective way to get a watertight closure around the ripcord that the tube comes with, which is a 4-0 Prolene. And so this has been really helpful. I found it, you don't really need this as much when you don't have a ripcord in there. 311 is doable, but when something about the dynamic of the ripcord for me, I needed a little extra cinch on that other side. And so this has been great. And it dissolves just like you would expect. I think Paul's technique is evidence that it doesn't really matter what type of Vicryl you're using or how many knots you throw, but it dissolves as expected. It pulling out the ripcord is as you would expect. And I have not severed a tube with this. So
No, I like that. I mean, I like the idea of really the compression forces on either side, flattening it out. And that's a really good point you made, right? I mean, I don't use a ripcord. And actually, Guggen just asked another question I think is really important. When do we use this ripcord? Do you use a ripcord? Do you do it for different kind of cases? I personally, normally for most patients, do not use a ripcord. I've been kind of like spoiled now because I think I've been pretty consistent with my outcomes with my non-ripcord cases. But do you use ripcord? And tell us when and which cases.
Yeah, so I do use a ripcord where I practice. Patients come from very far away to see me, Colorado, Nebraska, Iowa. So they're driving a long distance, and generally the tube is not going to open for me before 5 weeks. And so when they come in for that 5 week appointment, I can pull the ripcord there in the office and watch them. So I have them hang out a little bit. We open it, I give them atropine, we go over drops, make sure everything looks good, and I can review precautions with them. So it's like fresh in their mind that their tube has just opened and now their pressure's 3. And so it gives me nice control over that tube opening period because, if it opens spontaneously out in the middle of Nebraska where they're opening a feed bag in their barn, that's not going to go so well. So it's nice for me to have that control in the clinic.
Yeah, no, that's a really good point. I mean, I've used it on a couple patients here and there that I was kind of worried about, especially when I, do any kind of new technique at all. I'm always kind of worried about hypotony and worried about, control. So I think if you're really worried about control and you want to have that ability to kind of give some more eye flow right away, having that ripcord does help. Any techniques? Do you just do you just kind of leave it to the side temporarily to make a little snip, or any techniques on
Yeah.
how to remove it?
Yeah, I've learned the hard way on this a few times. So, like I mentioned earlier, the temporal conge is very thin. And also, you might have a suture line there. So, you want to make sure you dissect a little pocket as you're closing the conge and really tuck it down low under the lid here. Because if it's temporal under something like a pinguecula or the suture line, you're going to have a hard time pulling it out or identifying it. And patients can get almost um, like a big mound up of tissue where their vicryl suture is, like a granulation. So that's what I was trying to think of. And so having it covered by the lid is less likely to expose as well. So I've had a few rip cords that kind of poke out and bother people, and you trim it off and it just pokes out again. And so you're kind of waiting to open it. So getting it nice and buried down in that inferior temporal fornix is important.
No, I'm glad. It's so funny you brought it up because I was doing a case a couple weeks ago, and some of the New World medical folks were there, and they were watching me do surgery, and I don't use a lot of ripcords, so I was like asking them, like, how do I do a ripcord again? So, and so, I'm
Yeah.
like, but to your point, I mean, you want to keep it long enough because yeah, you don't want it to be poking up. That's the one thing I would say you realize is that you
Mhm.
want to make sure it's lying flush and flat against the sclera because if it's kind of pointing up and touching and pushing against the conjunctiva, it will buttonhole and cause some irritation, and so
Mhm.
you definitely want to keep it flat. That's the one thing I think would be important to make sure. So, um, let's kind of answer any more questions here. And then what we can do is talk about just real quick before we end any last minute kind of comments on post-op watchouts and kind of go from there. But I think we have one final question here. Can you ask this is from Guggen? Thanks, Guggen. Can you talk about your post-op steroid regimen? Go look at that. You're like perfect with all these questions. Regimen specifically around the time frame of when the tube can open. So basically, do you adjust your post-op steroids or your aqueous suppressants around when the tube should open up, and how do you do that? So go ahead and I'll answer after you.
Yeah, so a week of antibiotics, and then I typically start my steroids at, prednisolone 4 times a day, unless there's somebody I'm worried about inflammation on. And then I taper that down to twice a day. I like to leave them on a low dose of steroid. I don't want the tube opening and they're off steroid and they right around the time they could get some rebound inflammation. So leave them on steroid. And then also when the tube opens, you are going to get a little cell. And so low pressure plus cell equals hypotony. And so I think you want to keep them on a little steroid so they stay quiet. Um, Once the tube is open and things are stable and they're back at that next follow-up visit a week later, I start to finish their steroid taper. Aqueous suppression is just going to depend on where pressures are for me. So I'll let them ride a little bit high depending on their severity. You can tolerate maybe a couple weeks of maybe a few points over their target or something like that. But I'll go ahead and add it back one agent at a time usually, and then peel it off as we get closer, stop it a week prior, that kind of thing. But it can be hard to know exactly when it's going to open. So another reason I like the ripcord, so I can tell the patient, hey, I'm going to see you at week 5, stop your aqueous suppression the week before, and then it's a lot safer.
Do you tell the patient to stop doing activities at like a month out, 5 weeks, 6 weeks out, or do you just say do what you want to do, or just tell them no heavy lifting? What do you do?
Yeah. Because it's so rare for it to open before 5 weeks for me, I typically don't. Release them from their activity around 1 week as long as they're up over, 10 or something like that. And then I can resume it when I open the ripcord. So again,
Yeah.
it's like I get to counsel them fresh instead of relying on them to remember to do that at 4 weeks.
Yeah. Yeah. Luckily, I haven't seen a lot. I mean, I'm not sure if it's because of my 5-0 or not. I haven't seen a lot of hypotony when the thing opens up. I'm pretty like I'm lucky. I feel like I should knock on wood or something. So it's going to happen now, of
Mhm.
course. But do you stop I maybe I missed it. Did you stop aqueous suppressants? Do you try to hold off on aqueous suppressants? And can you tell the difference if a patient does come in with hypotony? Is it more ciliary body shutdown because of aqueous suppression, or is it overfiltration? Just talk real quick about that, and then we can end it soon.
Oh, that's a big question.
I know.
Um, I do try to stop aqueous suppression before the tube opens. Um, and I don't see a lot of inflammatory ciliary body shutdown because I keep them on their steroids through the tube opening process. So often I think it's just chronic hypotony. If you wait till 4 to 5 weeks after opening a tube, it's just not that common. I think, like you said, but um, yeah, I will stop the aqueous suppression before I open the tube and keep the steroids going. That's my main tip, I think.
Yeah, I think overfiltration for me, it sounds really weird, but I think it's really, peripheral chamber. If I see the periphery of the iris and chamber really flattening periphery like
Mhm.
this, that's really overfiltration. I mean, I very rare ever see aqueous shut down cause that kind of a kind of configuration. So I kind of look for that. But yeah, I think it's really rare for you to get these hypotony eyes that are really really scary. If there's a little bit of low pressure, they kind of come back up nicely. But
Mhm.
I don't really worry about that too much. I think with the ClearPath and with the 5.0 bike roll that I use, it's been pretty stable as well. Well, look, I think we are at time already. I did not realize it would go that fast, but okay, thank you to everybody out there for hanging out with us, for the questions, and to Lori for teaching me. Always, I love it. And Cassie, thank you for having us out tonight. It's awesome.
Well, thank you both for joining us this evening. For more information on ClearPath and the rest of our product portfolio, please visit newworldmedical.com and the Learn platform for training and practice resources. Thank you again, Dr. Singh and Dr. Provencher. It was a great webinar, and I hope everyone has a great evening.
Take care. Bye,
Thank
everybody.
you. Thanks, Paul. Thanks, Cassie. Have a good night.